Thank you very much, and thank you for the opportunity to present here today. And so good afternoon and congratulations to all of you to sticking this out of the last section of the last day. So I have no conflict of interest to disclose. And I'm just going to very briefly touch about the definition, the incidence, and then talk about the genetic mutation and clinical considerations for that are relevant to our surgeon perspective. The definition of early onset colorectal cancer typically refer to the cases that younger than age of 50, and the very early onset colorectal cancer is mean of the patient who's younger than 35 years old of age. And to talk about the incidence, this graph shows that the incidence of the mortality and both of male and female are decreasing since the 1990s because of we have the colorectal cancer screening program. But if the data on the right side of the screen highlight that the decline of the incidence of the average onset of colorectal patient. But if you look for another group that younger than 50, you will see the incidence is increasingly also as the mortality rate. So there's been a steadily rising of the incidence among the patient who's under the age of 50, and currently 1 of 10 are affected from the patient under the age of 50. So this diagram shows the individual incidence in each country. The red color of this chart represents the rising incidence of the early onset colorectal cancer patients, and this trend is also occurring in Thailand. So we should look at the metabolic risk factor for the young patient. Our data is still limited. The reason behind the predicted increasing in early onset colorectal cancer preference are not fully understood and are likely may be multifactorial. This is contrast of the average onset colorectal cancer patient, where the risk factors are already well established for now. So this diagram illustrates the presenting symptom of the colorectal cancer patient. The red and the pink present the individual younger than the 50 years old. So notably, this is a low number of screening colonoscopy in the young age group. Despite of if you see this, the red and the pink has a very high presentation rate, just like the bleeding per rectum, abdominal pain, and change in the bowel habits. So this is another data from the online survey in 2020. They revealed that the almost 54% of these patients have been diagnosed with one or more symptoms. The most misdiagnosis was a benign hemorrhoids. So if you have a young patient showing any sign that might need a colonoscopy, so it's crucial to send them for one. Don't just assume that the bleeding come from the benign hemorrhoid. And another thing that I want you guys to look at is the baseline characteristic. This data focus on the MSS tumor, which aren't linked to the specific gene, and it showed that the patient with the early onset colorectal cancer has a better physical fitness. But when we examining the state and the tumor grade, there's no significantly difference between the three groups. And this means the early onset colorectal cancer does not necessarily indicate a more advanced stage or more aggressive tumor to compare with the average onset. So there is something different, a little different between the three groups. The young patient often have tumor on the left side. Their colon and the rectum is especially common, but it a bit different from the older, where the tumor can show all around the rectum. Okay, this table is the wrap up about the patient characteristic. The young people with the cancer might show more symptoms, but they often take a longer time to realize that they need to go to see a doctor, and the doctor might misdiagnose them, leading to the delayed diagnosis. And in getting the right diagnosis, then leading to the late stage of the disease. And however, we will see some difference in tumor histology to compare with the average onset group. And then I will talk about the genetic mutation of the early onset patient. This pie chart highlights the big difference in the genomic mutation. The pink section shows a sporadic tumor when the patient don't have a genetic mutation, where the patient, we will notice the group that has a slightly smaller portion. When you compare to the early onset colorectal cancer case, and we have the blue section which represent the Lynch group that seem to be increased when the patients get younger. But they are all most of them they are all no germline mutation. And so we should focus on the sporadic tumor. We want to find the difference between the average onset and the early onset. So this paper run the oncoprint that they think it might help to find the answer. But it turned out that they didn't find any sporadic genomic alteration. Then we look at the survival and response. So the patient did not find any difference between the response up to the first line treatment or the site of first metastatic area or the outcome of the metastatic. So the clinical consideration from a colorectal surgeon perspective may be important. So I suggest the 4 key of to interest to focus: screening, counseling, and quality of life, and the fertility concern. So first, we have to discuss about the incidence with the screening. That when you look at the graph separately, you will see the decline in the incidence of the average onset patient, but you see the increased incidence of the younger group. But here's the key point. Even though the young onset is increasing, but actually number there is still so small. However, this trend rise is coming, so the latest guideline of ASCRS are now recommend start screening in a younger age. And another thing that NCCN now recommend in every case is to send for the multi-gene panel testing in every patient who has a colorectal cancer, which start under the age of 50. And this is another than the gene testing. So the tumor profile is also important. In this study, they suggested that the tumor sequencing, which tests for the tumor DNA, may have more specificity and sensitivity rather than the MSI or only ISC. And for another, the last one is the counseling of the patient. So because there are several common in approach between the early onset and the average onset. But in our young patient, they have a active life and a lot ahead them, so they might have been more expectation or something more they plan to do in the future. So such as the maintain their financial security and to do their job to get a proper management altogether, or they get the subsequent result from the treatment maybe affect their long-term lifestyle. And about the genetic and family counseling, so maybe we need to communicate with our patient and discuss all of their expectation. So I want to suggest you to see the financial toxicity in the young patient group, because they have a financial stress up to 71%, that maybe someone feel insurance is already covered, but they still worry about the financial instability in about future, and they were employed at the start of the treatment, but after that only half of them can still keep their job or can just continue to do the school or something like that. Another thing that you should concern is the ostomy issue, because after the surgery, 41% of the respondents have an ostomy, 28% maybe have a permanent ostomy, and 71% has temporary ostomy. But after they have the ostomy, they were more likely to take leave or quit work or leave the school, and maybe more than half they have troubling with the managing of their stoma, and it affect their social interaction or make them struggling with the intimacy with the other. So we should create the ostomy when the patient is really need it, because the result it may be not so good for the quality of life. And the last one that's the fertility concern, because the fertility is a crucial topic for the early onset colorectal cancer, because it's something that really matter at this age group, maybe 30 to 40 to between 50. From the data, we have about just 1/3 of the patients who have talk about the fertility topic before they go to do a surgery, and half of the women after the treatment they gotta be a menopause due to the treatment. So we suggest to routinely offer the sperm banking and the egg harvesting before we treat this patient group. And when you really get to know your young onset patient, you will see that from the moment the patient diagnosed with the cancer, the multidisciplinary team step in and guiding them through the treatment and surgery and following after that. We need to do the multidisciplinary team and help the patient to cope all the problems. So if you cope every perspective of the patient, your patient will have a good result of the cancer treatment and also good quality of life. So for my conclusion, about the genomic and the biological difference between the two groups is all the same and not more aggressive, and quite similar. The pathologic picture of the two groups may be a little bit more aggressive, but not so that big one. And so we should increase awareness of active to start the screening, because the benign bleeding of hemorrhoid is not always just from the benign disease. Maybe it can come from the cancer. And you have the high quality communication and use your multidisciplinary team in your hospital. And don't forget to offer your patient for sperm banking and egg harvesting before they start the treatment. So thank you.
Ladies and gentlemen, have any question for this topic?
Thank you for your presentation. I have one question, because the topic is colon cancer in the young age group, and then routine correct the sperm or egg. We still recommend for correct the sperm or egg, because it's a younger patient, maybe have a chance to genetic mutation. How do you screen before correct the routine correct the sperm or egg?
Because of if you follow the guideline, they say that we should have to send them from the multi-gene panel testing. So if everything is gonna be fine without the genetic mutation, they are sporadic case. So maybe they could have a chance to get the fertility reserve, because the every young onset colorectal patient does not mean that they have the genetic mutation.
So, any question? So, thank